All right, why don't we go ahead and get started? Thank you again for joining today's training on access to mental health services for refugees and other vulnerable immigrants in the U.S. This training is presented by Switchboard, which is a one stop resource hub for refugee service providers in the United States. I want to let you know before we get too much further that this training is being recorded. The recording for this training will be posted on the Switchboard site in the coming days, and you'll receive an email to the recording immediately after ending your participation today. One thing I also want to ask is that if you're participating in this training with more than one colleague but using a single computer, if you can please type your names and organization into the chat so that you know that we know who's attending today, that would be very helpful. I'm going to run through quickly a few WebEx logistics before handing over to today's presenter. If you're using the phone to dial in today, you can click the info icon in the upper left corner to find the dial-in number and code. That's at any time. If you don't see that icon for any reason, just mouse over the screen and that should appear. We also would love for you to participate throughout today's training. We have a few discussion questions, but also would welcome your comments and questions throughout. So the best place for those is to open the chat bubble, which is also in that icon tray at the bottom of your screen. Again, mouse over the screen if you don't see it, and it should appear. Then you can type a chat response, type a question, and if you send your message to all participants, everyone who's online today will be able to see it. One last thing to mention is if you'd like to raise your hand and have us unmute your line, you can do that using the small hand icon that is at the bottom of the participant list. You can see this is pretty small, so you can you can look at the image that's inserted there to see where that icon is. So if you'd like us to unmute your line, just click that during the designated Q&A period. With that, I'm actually going to hand it right over to today's presenter. I'm so pleased to introduce today's speaker, Dr. Suzan Song, who is Director of Child, Adolescent, and Family Psychiatry at George Washington University. She's also an advisor in the field of humanitarian protection.
Hi, everybody. Thanks so much. I'm so excited to be here, and I feel a bit strange that I can't see you all, but I'm really excited to be here today. Feel free to please do use the chat if there are any questions or issues that pop up since I can't see you. Just a little background about myself, in addition, is that I come from a both clinical and research background, so I'll be incorporating both of those. The clinical part was I was a medical director for a survivor of torture and refugee clinic for about 5 to 8 years. And then I also worked globally quite a bit with this population, and I'm also doing some research. So the objectives for this talk are really to summarize the research. And we know that what is in research and what's in practice can be quite different. And so it would be good to hear your experiences and your questions and to see how that matches up with what the current research says about the barriers and enablers for refugees, asylees, and other immigrants engaging with the mental health healthcare system. We'll also talk about four main types of barriers to accessing care that you might experience, and to also name 3 promising practices for how to support refugees in engaging with mental health. All right, so Meg, do you want to take on this poll question?
Yes, absolutely. So hold on just one moment and I will open up this poll. All right, so everyone should have seen that open up on their screen. We're wondering as we kick off the conversation today, currently, how familiar are you with the research on refugees' access to mental health services in the US? Are you very familiar, moderately familiar, somewhat familiar, or not familiar with the research on refugees' access to mental health services in the US? I'll just give maybe 15 seconds to answer this, so I'll close this poll pretty quickly. All right, so that poll is closing up now, just giving those who are in progress a little bit more time to complete their response, after which I will share the results with everyone. All right, so those poll results should be visible now, and it looks like there was quite a big spread among attendees today. Only two said they were very familiar with this research. 16 were moderately familiar, 28 somewhat familiar, and 21 not familiar.
Great, thank you. That helps give a good idea. And we did get some of your questions that you typed in before when you registered. And I'll try to incorporate those throughout the talk as well. So this talk is largely based off of a systematic review of the literature on the barriers and enablers for these populations that are listed here. Just for ease, we'll mainly focus on the refugee and asylum population, so I'll use the term refugee, but we really mean many of these populations. So why even the need for mental health care? Of course, you all know that there is a need because you're here. We know that many are fleeing war, armed conflict, pervasive medium and interpersonal violence. But we also know that these experiences are extremely varied. So some have prolonged exposure with human rights violations daily, like the Cambodian genocide and labor camps. Others have acute, intense, active exposure to war, like the Syrian conflict. Some might have migrations that are prolonged with lack of access to basic needs, constant threats to self and personhood. But others might have means and they can travel by plane or train, and it's not an extremely traumatic experience. Some people travel alone, others travel with their family. Some have relations here, communities and families in the resettlement state in the US, and others have really no one. So the post-migration daily life stressors also play a critical role in shaping emotional distress, with acculturative distress, traumatic loss of loved ones, the ambiguous loss of loved ones and not knowing where someone is, if they're alive, how they're doing, discrimination, all of this in addition to basic needs like lack of secure food, education, employment, housing. So a dimensional approach can be helpful, and I'll talk about this more a little bit later. But it's where we understand that oftentimes people are responding very appropriately to a very inappropriate experience of violence and violation. Not all of our clients will fit the DSM category. So we have to understand symptoms on a dimensional approach that emphasizes prevention and not this overemphasis on a diagnosis that may or may not be accurate. That being said, there are multiple studies, mostly of PTSD, depression, and anxiety, for this population of refugees and asylum seekers. And it shows a higher prevalence of mental disorders than the general population. About 1 out of 3 asylum seekers and refugees experience high rates of depression, anxiety, and PTSD. But systematic reviews show that the prevalence estimates of these disorders vary extremely widely, from 20% to 80% experiencing these disorders. So there was a question that someone submitted when registering about kind of the mental health after someone's been resettled in the US for a long time. And the research shows that most refugees and asylum seekers with PTSD and depression show a reduction in symptoms over time. And this is mainly if there are low resettlement stressors. But others can experience years and years of PTSD. And while these 3 disorders, like PTSD, depression, and anxiety, while they're commonly studied, there are many conflict-affected people who might not meet the diagnostic criteria, but they do experience like a complicated grief, complex trauma, despair, isolation, anger, and lack of trust. So all of that was a kind of a plea for why we actually need mental health care for this population. And now the question is, well, who provides the mental health care? Well, you all do, but many are not coming to see you. So how do you get them to come so you can serve them? And once in your office or in your organization, how do you know if you're meeting their needs? And how do you retain them in your service? This is also to remind you that it's not just you that provides mental health care, of course, it's the community. So the resettlement agencies, the community organizations, but also your own local population, like the religious and spiritual communities, the cultural groups. And it doesn't have to be people that provide mental health care, but the spiritual and natural beliefs about the world and the etiology of emotional and behavioral problems. Um, it can be a belief that provides their mental health care or spiritual belief. Also, families are the most proximal source of support. Now, I don't want to romanticize families because we also know that families can be the most proximal source of stress. Um, but for many people, the first point of contact are their families or their locals that provide mental health. So the IRC did a narrative review of the literature, which is very similar to a systematic review, looking at the gray and academic literature around the barriers and enablers of mental health care for refugees and other immigrant populations. Through all of this, basically there are 24 studies that met criteria, and that provides the framework for this talk. So it's just a reminder that this talk is somewhat, the examples are based off of clinical experience and organizational experience, but these barriers identified are really through a deep search of the evidence of what's out there right now. The approach that we'll use to organize the talk is a socio-ecological one, and that many of you have heard of. This is something, at least in the international humanitarian space, it's emphasized, which is a socio-ecological approach that identifies the individual, but only at the center of multiple spheres around them. And all of these levels, the community around them, which is family, peers, schools, work, the health systems around there, which is where many of you interface in, and the policy, these all affect the individual. And these are not isolated circles, but we should be thinking about how they all integrate and influence each other. The examples here is really just an overview map of what we'll be talking about, of what the individual and various level barriers are and enablers are for refugees seeking care. So we'll go through each level. This is the individual level.
Would love to hear from everyone in the chat about in your work. Suzanne's about to discuss the individual level barriers that the research showed. What were some of the barriers that you're aware of when it comes to refugees and other vulnerable immigrants accessing formal mental health services? And if you just want to type in the chat and send your message to all participants, we'll get a sense of the barriers that you're encountering. So seeing a few responses here, cultural differences and cost being two, speaking a rare language, transportation, interpretation, stigma, and definitely some similar themes, language barrier again, transportation, cost, lack of insurance. Thanks for participating in this, seeing quite a few great answers, access to culturally competent mental health services. Seeing some other great replies in the meantime as well. Emily shared definitely reliable transportation. Oftentimes, offices are located in a difficult to reach or unfamiliar area, which means that making follow up appointments on a regular basis is difficult. Yeah, I think that makes sense. Lack of providers willing to see refugees and immigrants due to lack of interpretation services, and that this takes a longer time, so it's not cost efficient.
Okay, so maybe we'll move through the individual level one. So comorbid physical and mental health disorders are one of the largest barriers in the research to having refugees and asylum seekers seeking mental health care. Having both PTSD and depression puts people at risk of physical health problems, and this is really regardless of their age. And so what we can do is we can take an integrated care approach. And for the rest of this talk, I'll kind of talk about what the barriers are that have been identified in the research world. And then we'll talk about some strategies, some practical ways that we can address those barriers. So for the comorbid physical and mental health barrier, we can take an integrated approach where many times refugees are more comfortable seeking physical care than mental health care. so we can incorporate behavioral health screening, referrals, and basic treatment within a primary care setting. And so we see there is a large push globally, but also here nationally, on integrated behavioral care, where you have a therapist or a counselor who's embedded in a primary care clinic, like a internist office or family practitioner's office. But it doesn't have to be in a physician group. I've done a lot of these mental health screenings at health fairs within different community organizations. So I did one at Afghani health fair. I did one for an Asian hepatitis B health fair. And it's really nice, actually, because they have the whole community there. And all you have to do is set up a little booth. And it's something like, they go from screening for diabetes, screening for hypertension, and then they screen for depression or anxiety or PTSD or any mental health issues right there. And so that can be a good way to increase referrals and intakes at your mental health clinic. So language was identified as one of the most important barriers to accessing services for refugees. This is, of course, very hard for rare languages where we don't have interpreters that speak those languages. We do have the culturally and linguistically appropriate standards that mandate the provision of trained, competent medical interpreters in healthcare settings. But this does not always happen, right? Because there are time constraints, there are lack of interpreters, or the legislation is just really poorly enforced. And as you know, the family, mostly kids, can act as cultural and language brokers, and this causes ethical and privacy problems. Studies with asylum seekers show that the inability to communicate clearly and effectively with providers led to frustration and to delay in diagnosis and intervention. So what can we do? Well, we build capacity to mitigate some of these language barriers. So Switchboard has really nice e-learning modules on interpretation. You can share the training both with interpreters and with healthcare providers. With interpreters, this is cross-cultural healthcare program, Bridging the Gap medical interpreter training. And then with healthcare providers, we have effective communication for healthcare teams. I think these references will be available if you'd like them. And at the end, you can ask Meg, and I'm sure she'd be happy to share them with everyone. And then a third individual barrier for refugees seeking care is legal status, of course, and fear or mistrust of services. We know just anecdotally, a lot of the agencies that I work with here, this is one of in the current political climate and times right now, this is one of the biggest barriers for many asylum seekers and undocumented people. So many asylees have experienced extensive insecurity before being granted status. They might have been subjected to torture or trauma, had experiences with authorities that have harmed them or failed to protect them. This can foster an ongoing fear over legal status, fear, mistrust of services. Detention, often over long periods, and fears over the terms of their release can be a really significant source of ongoing stress for those that are seeking asylum. And there were some qualitative studies that showed some did not believe that information related to their health would be confidential. Even though the provider says it's confidential, many just did not believe it would be. When asked to the healthcare providers, many providers thought the mistrust was not of Western medical care, but it was really a problem of establishing a personal relationship of trust. So building trust should be part of your treatment plan so that you have an alliance with a client who can then be forthcoming with their experience. So as an example, and I'll give examples because the ORR has asked for a lot of examples. I had one Persian client who kept telling me everything was fine, his medication was fine, his therapy was fine, in general, he was fine. But clearly, he was not. I met with his family members who said he has nightmares, he's had a hard time sleeping, he's always sad, he can't function. And when I explored more, it felt like he did not trust our interpreter. And I asked family members, and it turns out that he actually did not trust the interpreter because they had different political differences. So we therefore had to work building trust between the three of us. I couldn't find another interpreter. And so we just had to openly communicate about any potential hesitations or concern, and you put it out there in the open to help him feel more safe. So in the current climate, a lot of asylum seekers are scared. They aren't wanting to seek care. They think they'll be vulnerable, because they are, to arrest, detention, deportation. There's some studies that show that many believe hospitals and clinics might do a background check on patients and report them to authorities. So at the community level, what can we do, or what are some of the barriers? One of the most frequently cited barriers to mental health care for refugees is actually also an enabler. So culture. Many people have different health and illness beliefs. The culturally specific ways in which mental illness is explained, named, and expressed, and the cultural beliefs about the role and value of mental health services, like idioms of distress. But cultural sensitivity and cultural biases of mental health care providers might also impact access to care. So it's kind of what we as providers bring to the table, both positively and negatively. Refugees may express reluctance to engage in, quote, kind of, I don't like this term westernized, but that's the common vernacular, kind of westernized forms of healing, like psychotherapy, because the values around privacy, the beliefs about how appropriate it is to discuss personal and family members with a stranger. So in many, many cultures, one's family problems or personal problems, because our personal problems are a reflection of our family and our communities and our groups that we belong, many people want to keep those within, and it's not something to talk about with a stranger. And so we have to respect that. So it's not always clear if the reluctance to accept services is really a culturally based lack of understanding, or is it a response to services that are presented in ways that are really alienating culturally to newly arrived refugees. While those that are living in the US for a while may become more kind of aware and conscious of the prevalence of mental illness, the importance of treatment, other cultures may not acknowledge or even recognize the impact that emotional distress and disorder might have on overall health. So ways to address that barrier, we can really start by focusing on cultural sensitivity and competence. You know, we take stock of our own cultural biases and beliefs. I know we all, you know, and probably all of you are much more self-aware about the biases that you bring, but there are many that we have that are unconscious. And so you can take an assessment. There's a Harvard University implicit bias test. I believe that one's for free. And it's really actually, I think, quite eye-opening. It's a quick test that you can do to see where some of your biases might be. We can use culturally specific mental health assessment instruments that are validated in the language and context of your population. We can share training opportunities with other providers. Like there's one from the Office of Minority Health. And here is the link here if you wanted to see that for more resources. Healthcare providers sometimes can approach refugees with stereotypes of cultural beliefs and attitudes to mental health. And this can further reinforce rather than overcome the barriers to care. We can encourage mental health providers to shift from a biomedical disease model that focuses on psychopathology to more of one that's a holistic healthcare that focuses also on resilience. This kind of care would include understanding of one's traditions and norms, different explanatory models for distress, and also incorporate anything like non-biomedical causes like spirits, supernatural forces, nature, the influence of daily life, and have a very flexible adaptation to different cultural explanations and perceived ways of healing. We can incorporate idioms of distress and other local terms into care. So for example, I used to work with a lot of Cambodian survivors, and they often came talking about they were just thinking too much. And there is a Cambodian word for it I can't pronounce, but they would always say they were just thinking too much, thinking too much. So have that symptom be the focus of care as opposed to some DSM diagnosis that may or may not fit. And we can involve cultural brokers and refugee paraprofessionals. So refugees who are faring well and who understand the experiences of migration and loss, a culture of stress, discrimination that can be encountered while in the U.S., they can be very useful in assisting newcomers. We can also use a dimensional approach. And this is in lieu of a categorical approach, which is really a checklist of symptoms and criteria to meet off of the DSM. A dimensional approach would understand that many people have normal reactions to abnormal situations. So one should never be forcibly taken from their loved ones or have to witness, the murder of neighbors. War is not conducive to a supportive environment for development. So we have to better understand the distinction between a situational form of distress and a clear mental disorder by focusing on this interplay between the past exposures, the current daily stressors, and the core social systems that one lives in. Since exposure to trauma itself doesn't necessitate a mental health disorder, understanding what factors can promote well-being and protect against development of adverse mental health is imperative. And so we can use a stage approach, and this would evaluate dimensions of mental distress at various stages, or that symptoms are reactive and transient. So this would emphasize prevention. For example, a diagnosis might not be helpful for someone with a non-specific kind of distress, but if you had increased monitoring, support, and engagement, it could help with early intervention if the distress worsens and becomes really symptomatic. So an example, I was working for a while with a Syrian refugee woman, and she was ruminating in distress about her daughter who was now in the U.S. and dating a Christian boy. Her daughter no longer wore her hijab. She always wanted to be out. Now, my client, she wasn't suicidal. She had no change in energy and sleep. She didn't really have kind of a sadness. It was more this feeling of deep disrespect and despair. She did not meet full criteria for any depressive or anxiety disorder. So I followed her lead. She wanted to talk about her daughter's disrespect. That led her to talking about how her husband was killed in Damascus along with 2 of her sons. She feels really alone. She's scared she's going to lose her child in the U.S. And she just finds it really disrespectful that her child is not adhering to her kind of cultural and religious norms. So this allows us to address both the pre and the post-migration stressors. And then we can take a resilience approach. So we can identify how she's gone through something. I asked her, what have you gone through in the past that was really, really hard? And this is even before the war. Was it religion? Was it prayer? Was it talking to people? And through that, she can identify, yes, I have been through something hard in the past. And I realized that talking it through with my loved ones was really the most helpful thing for me. We had dyadic sessions then with her and her daughter. And after 3 to 4 sessions, they both felt heard and understood. This would have been very different if I just diagnosed her with major depression and we focused only on her past kind of horrific traumas and prescribed medication. Okay, so social stigma is also a large barrier. It's somewhat related to culture, but many studies identified stigma as an important reason why many refugees are unable to access care. And here's a quote from one of those studies that says, psychiatric problems are not accepted. If you have psychiatric problems, it's because you're a bad person or you're crazy. I used to work in Sierra Leone with former child soldiers. I remember talking, Sierra Leone had one psychiatrist, and he said, people here think that I'm crazy because I can understand and talk to the quote crazy. So this is, worldwide. So what can we do to address the stigma? We can really emphasize social networks and informal support. So studies show that early recognition and intervention by social contacts, such as friends, family, neighbors, that those might mitigate mental health problems, or they might even obviate the need for formal mental health services. So social context can serve as critical linkages to formal mental health services. Also, we can address the socioeconomic stresses like employment, housing. Those can be a means, by addressing that, it can actually reduce the risk of mental illness. So there's a study, I think it's a Ballard King study, where Bhutanese refugees have practices of care that are rooted in strong community relationships. The study shows how they describe how social support actively monitor and respond to signs of distress before a mental illness can actually even becomes clinically apparent. And so you embed people in your community that understand how to work with emotional distress, and that they know they work with you so that they can refer people when it becomes more serious. Post-migration stressors are also clearly a barrier to having our refugees seek care. These are the collective challenges and socioeconomic pressures that are faced in the process of adjusting to their new lives in the US. These are basic needs like food, access to food, shelter, employment for themselves, for their dependents. There is an old debate in the literature about whether it's more important to focus on the pre-migration trauma or the post-migration stressors. There's evidence that both the traumatic exposure as well as daily life stressors can worsen mental health. So it's best to incorporate both and kind of meet the client where they are. Oftentimes, helping with the daily needs can start to heal some of the feelings of helplessness and despair that they might feel due to past experiences. So at the health systems level, we can talk about some of the barriers there. One of them is limited availability of services. So studies report that refugees often have very few options for accessing mental health services. This is why it's so important that all of you are here. I'm assuming that many of you are here because you serve this population. You want to serve their mental health needs. It also means that you probably are the only ones in your area that are offering mental health services for this population. So you have very important roles in their lives. So the limited availability of services can include the lack of consistent programs to address the specific needs of refugees. There can be oversaturation and long waiting lists. There's already a long wait list for the general population to access mental health care, let alone for these specific kind of services. And where services are available, it's hard to coordinate the various professionals involved. It's a very, our mental health care system and our healthcare system in general is very complex. So, Meg, can I give you this discussion question?
Yeah, absolutely. And this is an opportunity for those who would like to unmute to raise your hand and do so. Or you can, of course, type in the chat as well, as you all have been doing. We're curious, Suzanne just mentioned some of the barriers at the health systems level, access to services and availability of services. What are some strategies that you or your agency do to facilitate that access? If you'd like to participate aloud, just raise your hand. The icon again is down at the bottom right of the participant list on the right-hand side of the screen. Or I'll also take a look and see who's typing in the chat. You can send your message over chat to all participants so that everybody can read your response. Okay, so one response so far from David, who says bilingual providers. Sure, I think that this is an interesting response. Suzanne mentioned cultural linguistic competency earlier as well. Be curious to hear bilingual providers, how you work with them, how you facilitate that relationship. Rupa shares that they've created a working group of mental health professionals and reached out based on language and availability. Really interesting. May shared education sessions on what mental health is and exercises to release stress. Thanks for your responses so far. Apologies if you can hear any sirens in my audio. I'm sitting in Manhattan today. Oh, great to see a lot of great responses coming through in the chat. They always come all at once. Caitlin says, we refer to counseling services actively and early in the resettlement process. We know of 1 to 2 service providers in the area that provide interpreters. Beatrice uses prompt appointments with the primary care provider to get a referral for mental health services and reaches out to new mental health care providers willing to work with refugee populations. Bahadur shared that we have staff who are licensed social workers who access and provide the basic assistance but refer out better health services. Thank you all for sharing these different strategies. Looks like a lot of linkages, a lot of partnerships that you're involved with to help mitigate this barrier at the health systems level. I don't know, Suzanne, do you have any thoughts on those strategies that participants have shared?
Yeah, those are fantastic. And I'll just pick up, and they were all quite good. I'll just pick up on a couple of them. So one is the working group that you mentioned. I think that's really impressive. I think more interagency and kind of interdisciplinary collaborations are always fascinating. You always learn so much when you meet people from outside of the field, um, outside of your field. And so I think that working group, the more we can collaborate with everybody, there's a working group that's developing around where I am. And we've included people from, of course, from education, but also from employment and labor, and health, of course, mental health, different community agencies. So it's been really nice to learn from everybody and to kind of collaborate to build a really strong support network. The active and early engagement is really critical. There was a study that I did a little while ago. This is on survivors of torture, which includes some refugees and asylum seekers. But it showed that there's a critical time period in the first year of arrival to the US. So that people who receive or seek mental health care in the first year of arriving to the US, they have much better outcomes than those that wait for over a year before they seek mental health care. So it also speaks to, thankfully, mental health services are helpful, like they're beneficial. So getting people in earlier can really help. That's also why this kind of a dimensional staged approach to mental health can also work in your favor, because it helps with identifying early, quote, symptoms that might or not be symptoms, but forms of emotional distress, to just monitor that and then to engage them into services when it becomes more problematic. Great. So other things we can do to help engage people into mental health care. We can provide intensive case management and care coordination. So we know that it's really hard to schedule appointments. There's a mention about how difficult it is for transportation. There's also a comment about childcare and how it's just really hard to get to the first session. So if you can have intensive case coordination, that can help. We can also screen systematically and provide follow-up support. The CDC has recommendations for screening, mental health screening for this population, but it's inconsistently conducted for newly resettled refugees in the US. And the screening practices differ significantly state by state. It's not the only problem, though. There are very few culturally appropriate screening and assessment tools that are validated for use in these populations. So right now, I think one of the nicest ones, there are some out there that are long and I think they're hard to administer, practically speaking, but the RHS-15, the Refugee Health Screener, it's very quick. It's got, it's validated in a few languages. It has good research and evidence behind it. I think it's one that we should be more systematically using. It's only 15 questions, and it is just a screener. So it's not diagnostic, but it's just a screen as to whether or not someone could benefit or would need mental health care. One study on refugee women in OB care had a program that used innovative approaches. They used the cultural health navigators, strong interdisciplinary partnerships, and to promote access to care. 22% tried to complete the RHS-15 but couldn't because they didn't have it in their language. Half who screened positive did not follow up. Another study showed that almost 60% of those who did screen positive on the RHS-15 followed up with a primary care provider, but only half requested treatment. So a positive mental health screen and referral is important, but it might not be enough to ensure access to mental health services. So if you do a screening, which I hope that the people are all doing, if you do a screening and someone screens positive, it's not enough to just tell them that they need to go or give them a referral to a mental health provider. It would be nice if you could do a warm handoff, like actually walk them over to a clinic or use a navigator to help accompany them or to follow up to make sure that they are going, because just screening positive and giving a referral is not enough. So we need to really work to foster stronger communication and trust amongst patients and providers and all different kinds of providers. So for youth, we didn't focus, the study did not focus on children or adolescents, but we do include this here if you do work with youth. The school can play a central role in the lives of resettled refugee youth. School-based mental health programs can provide support to kids in a very accessible and non-stigmatizing setting, provide security, stability, routine, improving the school environment and the experiences at school can improve mental health outcomes. The staff can monitor the social emotional functioning of refugee kids. They can identify signs and symptoms of problems and intervene early. There's a SHIFA program that's supporting the health of immigrant families and adolescents. This was a school-based mental health program for Somali youth based in the Boston Public School, and it offers culturally competent services, community engagement, outreach to the parents, early identification and intervention, and also specialized mental health care, and it's adapted for Somali culture, including trauma systems therapy. So this program was shown to reduce stigma and build trust. If anyone's interested, there is the citation there. So the fourth level, this guy is a higher level that we don't really have that much control over, are the barriers on the policy side. So managed care and compensation, of course, is a main barrier. The focus on cost effectiveness and efficiency that defines managed care can limit a comprehensive assessment and long-term treatment options. So compensation for services really pushes people towards short-term symptom-focused approaches when really there should be an incorporation of community and family interventions that have more of a longitudinal eye approach. And unfortunately, studies show that mental health services in both the public and private sector just vastly differ in range and quality of care. Health insurance and an affordability of services. This is one of the main reasons why people cannot access care. It's both the lack of clarity over the cost, which discourages people, but even when they're eligible for Medicaid, the application can be so complicated that it prevents people from accessing it. But that's not everything. So there's one study in Boston that showed that even if the uninsured are covered by Boston HealthNet, which can basically grant them access to care, a high number still declines care. And so what could be going on? Well, some of it is perceived discrimination. Some refugees regarded health service providers as really being motivated by financial gain. And they also felt that if they were insured or unable to pay, that they received a poorer standard of service compared to a US citizen. So some of the summaries and recommendations of what we can take away, hopefully, from this talk. One of the barriers is inconsistent mental health screening. So what we can do is we can systematize the screening and referral process. We can use RHS-15, and you can systematize that by reading the script, by having all of your clinicians administer it in the same way, be consistent. If it's positive, we try a warm handoff to the provider if possible. We just try to minimize any logistical barriers. Another barrier is the limited cultural and linguistic competency of providers. So we really moved towards capacity building and trainings. We moved beyond simply providing an interpreter towards a more respectful communication and understanding of the context, both past and present. We train to be sensitive to ethnic and political identity, the culturally specific ways in which mental illness is explained, named, and expressed. We can be flexible in meeting the client where they are, whether it be on past traumatic exposures or to current daily life stressors. We can confront their own, have clinicians confront their own cultural biases, and we can use a dimensional approach to understanding emotions. And for lack of validated assessment tools, diagnostic tools, everyone uses the Harvard Trauma Questionnaire and the Hopkins Symptoms Checklist. That's fine if you're doing studies or to present data for the ORR reports, for example. But if you're an individual clinician and you're really working with someone, not in a research setting, but just on an individual level, honestly, I would just use the patient's vernacular on what their distress is. And that is your measure to follow up with. So for example, when Cambodians say too much thinking as their main problem, I wouldn't change that to depression or dysthymia. We take it for what they say, and we say it's too much thinking is their symptom, and that's what we want to target. So some of the factors that foster refugee resilience, I'll put these here throughout the whole socio-ecological levels. These have been shown in the literature to be helpful to building resilience. These also, I think this is a nice slide because you can use this to integrate into your own treatment plans and treatment goals. So family support, for example, at the family level. If one of your clients has family nearby or family that they feel connected to, they should be part of your treatment goal. And part of your treatment plan is to increase family strengthening and a sense of family belonging, and that could be one of your goals. So I know we have only about 7 minutes left. I'm going to hand it over to Meg, to kind of give some resources and Q&A.
Thanks so much, Suzanne. And thanks for ending a few minutes early so we can have some Q&A. Before we get there, I want to mention that all of the content that Suzanne's talked about today, the different barriers that the research supports, and the strategies that she discussed that can be implemented to help address those barriers, along with the full citations for anyone interested in really digging into the research evidence, by finding those individual studies. All of that's available in downloadable format in an information guide called Access to Mental Health Services for Refugees and Other Vulnerable Immigrants in the U.S. You have a screenshot of that to your right on the slide here. That is going to be emailed to you after this training. Something else that has come up, I saw a few questions on this during registration and the chat during today's training, is the question of referral networks and cultural competence. Switchboard did do a webinar that some of you may have attended on building a culturally informed network of refugee mental health care providers, and there's an information guide on that topic as well, so that'll also be sent around to you. Our e-learning that Suzanne mentioned is on our site, Introduction to Working with Interpreters and Overcoming Challenges in Interpretation, as a starting point for building capacity in that area. And of course, you can always submit a technical assistance request from Switchboard if your organization receives ORR funds. Any grant from ORR, any type of funding from ORR, it makes you eligible to receive customized support from us on the questions or challenges that you might be experiencing. You can find more information about that on our website, and that's, of course, at absolutely no cost to you. All right, that's my spiel. I've added a few resources into the chat. I'm going to add one more right now as well on the RHS 15 since I saw a question looking for that. I believe I added links for all those who were looking for links specifically. Are there any other questions that were not already submitted? Please go ahead and type those in the chat now, and we'll start with one that I saw earlier today, and you started to allude to this towards the end, Suzanne, but outside of the RHS 15, is that the real, as far as a screener, is the RHS 15 the one that you really do recommend, or are there other options that folks should be considering? I know that a question of age and others have come up about some of the limitations of the RHS 15.
Yeah, thank you. It's a very good question. it's one that I've been looking at quite a bit because it, the other screens I've seen, and I can't list them off the top of my head, but the other questionnaires I've seen, and I've tried a couple of them. Some are too long. I don't like giving this population any sort of questionnaires that are more than 20 questions. I just think it's too much. People get fatigued and they start to feel like it's an interrogation. So because of that, I have tended towards the RHS-15. It's also the one that has the most research and evidence around it. It doesn't mean that it's, quote, the best. It just means that, Michael Hollisfield has done a great job researching it. It is also validated in multiple different languages. I think there are now 5 languages, which is pretty good for an instrument. So for that reason, I do use it. I know there is concern about the age. It's something I actually was going to work with Michael Hollisfield, who developed it, on researching, doing a study about whether or not it's appropriate for, what age for children, whether it's, 14 and above or else, something else. But that would be the one that I would choose. And especially if you're working with primary care providers, they don't have a lot of time, and so they're going to want something very, very quick to administer.
Great, thank you for that. You touched on this a bit earlier with your examples around the Syrian client that you were involved with supporting, but someone has asked a question about religion. Can you talk a little bit more about what aspect religion can sometimes play for individuals with mental health issues? And this person is particularly interested in the context of East Africa, if you happen to be familiar.
So that's a very hard question to distill into a small. There are many, many books around religion and spirituality and mental health. James Griffith is an author who I think I really like his work. It's quite accessible to people who are non-researchers. He's a clinician. He's written a lot around spirituality, religion, and the intersection with mental health. So basically, religion and spirituality, it can shape one's understanding and experience of what even emotional distress is. Now, they're both pros and cons, just like families are, in how mental health is managed. So while religion can be a source of support, it can be the main coping tool for people to seek care from. It can also be a large source of stress. And this is when either there's some religious ideals that don't match with their larger the mainstream community, or they feel isolated in some way. The issues around, or the question around East Africa, so I worked in Burundi. My PhD was in Burundi for about 4 years, and I think it's hard to really. I can't. It's quite a general question because there are many different religions within East Africa. And I think in general, with all that we're talking about, with culture, with religion and spirituality, it's not that we have to understand every specific religion or culture. It's that we try to figure out, we take a very individualized approach to understanding what that person's religion means to them and what that person's culture really is. And I do this a lot with families. So families, we might expect that a family from Burundi is, acts in a certain way, but really each family has their own culture, and the individuals are embedded in that family. And so what is that family culture like? What is the context like? And so when you're asking the question about the importance or the impact of religion with someone from East Africa, I would reframe that to asking the individual being more curious about what their religion is and how it plays a role in their life. And from that, you'll better understand the person's context and culture and spirituality and religion and how that affects the way they perceive emotional distress. I hope that makes sense.
I think so. Thank you so much for that. With the understanding that some folks may need to run because we've reached the end of our time limit, I think I'll ask one more question that was submitted. And if there are others, don't hesitate to type them in now, and we can always reach back out to you later on if possible. So this question is, outside of, quote, Western one-on-one counseling, can you speak to any promising practices that support refugees regarding mental wellness? For example, movement therapies or others you might be aware of.
Yeah, that's a great question. There's a lot of, it's hard because there's so many practices. There's evidence-based practice, which is when we have these interventions that are well researched and studied, and they've gone through a rigorous, um, randomized control trial. But then there's a lot of what I've seen mostly globally, which is practice-based evidence, where people are doing practices, they don't have a lot of research behind them, but they just know that it works. These organizations, the people, they know that it works qualitatively, anecdotally. Movement-based kind of work, there is a growing body of literature around that. There's a lot around somatic therapies, which is really an engagement more in the body, and it's not so much focused on kind of the cognitive, the mind, and affecting our thoughts and our feelings in that regards. There's a lot of art. There's a lot more evidence right now building around art and art-based therapies. That could be also very important because I think a lot of refugees coming from the more what I call it a being society. The colloquial word is kind of a collectivist society, but I really mean it's more of a being instead of a doing society. So doing society is like in America, like we're all very individualistic. We're focused on achievement, accomplishment, individuation is the main goal. Let's say like adolescents. Whereas if you're from a being culture, it's very different. It's about being part of a community, a part of a relationship, part of a family. It's about your role with another. Um, so oftentimes many of these therapies that are focused on the individual and the cognitive aspect, they're quite foreign to people that are from a quote being collectivist society. And so anything that engages more in the physical or the dance therapies, the dance movements, arts, these can all be really helpful. Like there's a lot of music therapy as well. These can be more easily embraced for other people.
All right. Thanks so much, Suzanne. I think what we'll do now is go ahead and wrap up. You'll be prompted to take a feedback survey at the end of today's presentation, and you'll be asked whether you feel today's learning objectives were achieved. Just a reminder that we're hoping that after today, you'll be able to summarize some of the research on this topic, that you'll be able to describe those 4 types of barriers that Suzanne went through in that socioecological model, and that you can name a few promising practices to support refugees in engaging with mental health care. If you'd like to stay in touch with Switchboard, you can find us at switchboardta.org. That's where you find information for submitting a TA request if you'd like to continue the conversation on this topic. You can also reach out to us over email, find us on Twitter as well. Thanks so much again for all your participation today and your patience with the audio challenges that we ran into, and for giving us an extra 5 minutes of your time. I want to give a huge, huge thank you to Suzanne for presenting today and for being involved in this literature review process with IRC for some time this year. I really do hope that the information guide that Suzanne put together will be useful to you all. Thank you so much again, everyone.